Thank you, sir. So I thank the organizers for having me here and allowing me to share my thoughts on this important aspects of addiction and cancer pain interface. Now, what interface are we trying to talk about here? The cancer as well as cancer and the consequent pain due to cancer. It has multiple relationships with addiction, as briefly highlighted by Professor Atul. One is that pre-existing addiction, for example, tobacco addiction or alcohol addiction, they themselves can lead to cancers and subsequently the pain that happens. The use of certain substances can be as a response to cancer, to self-medicate, to feel better, to get them relieved. And treatment for pain, they often require use of medicines which are sometimes addictive. So I'll talk about these three things briefly. Addictive disorders are known to have genesis of many types of cancers. Particularly, tobacco has been linked to several type of cancers, and of them, the highest odds seem to be for lung, larynx, and pharynx cancers. But apart from that, there are many other cancers that happen due to tobacco. The risk is higher for those who have been actively taking tobacco for long periods of time as compared to those who have been taking for shorter periods of time or have quit tobacco. Similarly, alcohol is associated with several types of cancers with strong associations noted for oral cavity and pharynx cancers, cancers of the esophagus and larynx. There are other less strong relations with cancers of stomach, colon, and rectum, etc. There are certain cancers which are found to be not related to alcohol use or alcohol use disorders. Now, similarly, people have looked about whether marijuana or cannabis have been associated with cancers, and there is not a robust relationship except testicular germ cell tumors. Apart from that, other cancers have not been associated. Opium or opioids have been associated with certain type of cancers, and cocaine has a weak probable relation with certain cancers of head and neck. But apart from that, no other strong relationship. So hence, substance being important predictor of cancers happening, substance use is not rare among people who are suffering from cancers. In studies with different kind of population, different kind of settings, scenarios, the rate of substance use or substance use disorders has ranged quite considerably from 2% to about 35%. So there is a variability in how you go and assess and what do you ask people. If you just ask of what substances they are taking, the rates are higher. If you are very scrupulous and you want to find out how many people are dependent on substances, the rates are lower, but still nonetheless, they are there. Now, several variables are associated in people who have cancers with the presence of substance use disorders, and these include psychiatric comorbidities. So, as we discussed, that there are psychiatric comorbidities, and Dr. Preeti told us about that. So, if you find psychiatric comorbidity, there is high chances of uh, substance use disorders also occurring in those patients. In younger or older veterans, it has been found. I use the word veterans here because it has come from one particular study where they were looking at veterans. When people are less likely to be married, they are more likely to have substance use disorders. Samples taken from metropolitan areas, they seem to have more substance use disorders as compared to rural areas and in certain population groups as well. There is a high heterogeneity and the prevalence of opioid use disorders. We talk about opioid use disorders because this is one of the common medications that are given is around 8%. The risk of opioid use disorder seems to be higher. So risk is something when you use certain screening instruments to find out whether a person is at likelihood of developing an opioid use disorder or having an opioid use disorder. So you are catching more number of people, but not all of them will be having opioid use disorder. So these are some of the screening questionnaires that are used and which have questions like, do you have mood swings? Do you smoke a cigarette within an hour of waking up? Do you take medication other than the way it was prescribed? So these are certain indirect questions to find out whether the person might be misusing opioids. So herein you catch a lot of people, but not all of them have opioid use disorders, and just a proportion of them will be having opioid use disorders. So risk of addiction does not mean addiction happening. These are just preliminary pointers. Now, in a case where a person has developed cancer, there can be many reasons why substances are being taken or continued if the person had been taking in the past. It may be due to the craving, which is a feature of substance use disorder. So, a person having substance use disorder has a craving or an intense urge to take substance. So, that might be present even when the person has developed cancer. Apart from that, it may be to deal with negative emotions due to cancer, and that may be due to the treatment, due to the diagnosis, due to the shortened longevity, due to the circumstances that have occurred due to the cancer. To ease the pain due to cancer, so the cancer itself might be causing pain, and to relieve that pain, there might be continuation or use of substances, and also to counter the side effects of the treatment. So treatment often is necessary and helpful, but it causes side effects. So that to counter those side effects or to ameliorate the distress due to that side effects, people may be taking certain substances. So when we talk about cancer and pain, there today morning, as we discussed, there is a physical component and then there is a psychological component as well. And opioid seems to be taking care of both. So the physical component of the pain is reduced as well as the psychological component of pain is reduced. But apart from that, when we talk about alcohol and cannabis, and they also seem to relieve some kind of psychological distress, primarily the psychological component, not the physical component of pain per se. Now, let me give an example of a case I've been seeing in my clinical setting. And I treat in the National Drug Dependence Treatment Center, where we find people with opioid addiction commonly being treated, and we treated with opioid substitution treatment. So here was a 55-year-old male with opioid dependence who was following up regularly with me and our center, who was stabilized on 18 milligram of buprenorphine, which is an opioid substitution treatment where we give buprenorphine so that the person does not relapse back to heroin. And he was being given on a weekly dispensing of this medication. So he is okay. He is rather functional, but he developed hoarseness of voice, and then a biopsy was done after a couple of months, and which turned out to be uh, cancer of the larynx. He also had tobacco dependence for a very long period of time. We tried, but I'm not sure whether he stopped at all. So he wanted to go to Punjab for initiation of treatment, and he requested 2 weeks of medication. Now our policy is to give 1 week of medication. He requested for 2 weeks. We agreed. Uh, Treatment was not started there. He had some family members there, but it could not materialize, and that happens. And he was told about surgery and radiotherapy that should be done. So he knows what the treatment is, but it could not be started. Uh, he thereafter he tried to seek treatment at other places, and he was given 2 week medications once more in a while. But then he himself started to report that he is taking more opioids than what has been prescribed. So he has been prescribed something, and then he's taking something more for his pain control. Now here uh, he was offered as admission to, we wanted to see whatever dose he requires, we can try give that. He declined. He did not want to get admitted, so that which would give us a window of opportunity to see what dose his requirement is. And thereafter, once a son came to take medication on his behalf, we still gave to the son, but we gave at the usual dose and not an increased dose. So question to me as a clinician was, should we tweak the OST dispensing policies in patients who have cancers, right? So they deserve probably our sympathies, but do we need to have policies in place to be more friendly to them? And the other thing, should we be more liberal in increasing the dose? Here, the patient says that he wants increased medication. There is no way for me to corroborate that he is taking excess medications or not. Admission is not on the card. So how do I proceed? So these dilemmas remain. And why I think bring up this case is because, there can be many things written in the books or guidelines, but when you have a patient in front of you and where you have to apply your clinical judgment, there can be certain things that you need to consider. We know that opioids are likely to be used in treatment in the cancer pain, and the WHO ladder provides opioids at two different levels. One is for moderate pain, we go towards codeine and tramadol, and for more intense pain, we go towards morphine and fentanyl and buprenorphine and methadone. Methadone is available, buprenorphine is available, fentanyl and morphine all are available in India. Opioids are known to be effective and addictive painkillers, and they are mainstay for cancer pain. They have been less frequently used in India as compared to worldwide. And many people who require such medications for pain control do not get that. And that is a reality here in India. Uh, but the question in front of us sometimes is whether the person is taking opioids for cancer pain relief or for getting some kick out of it, or both. So it may happen that the person wants to be just relieved from pain, and that might be the main motivating factor. And that is often the most commonly motivating factor, that the pain relief should be there, and opioids do a good job towards it. So what do we think about? So we want rational use to be there, that what we were giving as opioids there in the prescribed limits or whatever is required for the patient. But we also are sometimes thinking whether we are being deceived when the patient wants to get a fix or not. And we are not good lie detectors. So doctors are not good lie detectors, that we know. Uh, if it is, should we think that this is probably patient's last wish, and let us be considerate, right? Especially for terminal situations. So this is another consideration that might come into our mind. And related to that is whether it is a slippery slope, whether if I do it for this patient, whether do I take a similar stance for another patient with less severe problems, and what is the lowest threshold I'm willing to be cooperative for, and whether the legal framework allows me to be helpful to the patient or not. So these, as a clinician or as a pain prescriber, these are certain things that I'm sure would come to the minds of the clinicians. So what should we do clinically? There are guidelines from the Indian Society for Study of Pain, Cancer and Cancer Pain, which suggests that they have particular suggestion for how to keep check on opioid abuse or misuse. And they suggest that check the remaining stock of opioids by pill count, checking wrappers, history of amount of medications consumed, etc. Assess the pain and disease status on every visit, and whether they are seemingly correlating with each other or not. So if requirement is high, does that mean the disease has progressed? If the disease has improved, and if the requirement is getting higher, then probably there is some kind of a discrepancy. Check if the patient is getting opioids from other physicians or not. Check whether pharmacist is about other pharmacist about the medication being given. And is the patient accompanied by different caregiver every time? So the caregiver does not know whether the patient is getting the medication, or the caregiver is coached to tell that no, he requires this medication, and the clinicians are also kind of reassured that okay, there is a caregiver, we can give the medication that is required. So probably it's an elusive balance. We need to balance out. There is a requirement. At the same time, we need to be a little cautious at times. So most patients with advanced cancer will have pain requiring opioid therapy at some stage during their disease course. And this is as per certain guidance that has been given by Pinkerton and Hardy in adult and adolescent patient when we go about it. So majority good pain relief is there with apparently not much side effect. So opioids as painkillers should be used. A subset will have substance misuse issues that will influence the management and prescribing practice. So because some people misuse, and we don't know very well who will misuse, that's why we need to be cautious for all. Both a judgmental or a relaxed approach in such patients is problematic. If we are very strict to everyone, then we are not able to help many people who require help. But if we are too relaxed, then probably we are fueling the addiction which is developing in people who have developed cancer, but at the same time have addiction as well. So when do we suspect that there is problematic opioid use? When there is overwhelming focus on opioid use. So the opioid issues in the clinical setting. So the patient comes and says primarily about कि मुझे दवाई चाहिए, ये चाहिए, or rather and tells less about कि उसको दर्द कहाँ है या उसका treatment में क्या चल रहा है. If the patient has a pattern of early repeats or escalating the drug use in the absence of acute change in the medical condition, if the patient generates multiple calls or visits or coming primarily for opioids, कि मेरे को control नहीं हो रहा है and I need to increase the medication. There's a pattern of prescription problems for a variety of reasons. That may be lost prescription, कि I've lost my medications, I've lost my prescription, I do not have medications. And the patients have supplemental sources of opioids from multiple providers. So these can be indicators when you can think that there is a problem. Now, let me bring in a focus of a case which has been published in one of the journals what are the challenges and what are the opportunities in such cases. So this was a female with Hodgkin lymphoma who had been started on ABVD treatment. Uh, and what has been happening apart from the treatment and the cancer progression was that the person has heroin dependence as well, and the person would be lost to treatment. So when you have a patient with addiction, sometimes the addiction might be overpowering them and not making compliant to treatment. So you might get them. And another thing that may happen is managing them in the inpatient setting might be a challenge. So that is another thing that we need to be cautious about. So in this case, when you see in cycle 5 in December 2014, there was aberrant behavior while in an inpatient setting. Uh, and the kind of aberrant behavior was that the person was admitted at that time with heroin, morphine, codeine, diphenhydramine, and methadone positive in the urine. And methadone was continued. She received treatment for her addiction as well, but despite that, she would take other opioids as well, and she was found unconscious in the inpatient setting, but she recovered. So apparently, she got overdose, and then she was okay as the dose reduced, or the effect of the drug reduced. The security searched the hospital room and found a full syringe of an unknown substance. So they don't know what was there, but they still found a syringe. So the person had access to something and injected it. Then the room. So what was done as a consequence was the room door was left open for the remaining part of the stay. She was not allowed visitors, and staff member was present for remainder stay of the hospital. So this is what the clinicians in that hospital did, so that the person would not inject again or would not misuse again. Another thing that was done was she did not get any prescribed opioids at the time of discharge. So this was probably a stance taken because of her injecting behavior that she will not get opioids. So this might look a little stiff to her, but this was how. I thought of bringing this case because this has been published, and nonetheless, and second, it gives a real world scenario of how things unfold. Psychedelics is another group of substances probably which have been used in treatment, and in the past LSD has been used in patients with cancers, and seemingly LSD was significantly better than hydromorphone and meperidine and almost half of the patients were pain free after 19 hours. So this is some data more than 60 years back. Probably we cannot use LSD anymore now, but nonetheless such evidence exists. And in 1998 MDMA has been used for pain relief in a patient and reported to have some benefit. So in a single patient case report, but nonetheless use. Now let me bring to another small clip. The voice won't be here, but the point I want to raise is there's a no need, no need. Whatever she says is she says this is from film Queen. This is Kangana Ranawat, and she says that she gives an example of Mr. Gupta. Mr. Gupta has cancer. He has never smoked. He has never drunk. उससे अच्छा तो वो पी लेते है ना. So the issue is that what happens if we should we stop people who have developed cancer from using or trying out substances, or who want to try out substances? So this is just a food for thought. Nonetheless, in advanced cancer also, we need to manage addiction in a proper manner, or at least give some forethought to it. Because due to addiction, there is increase in patient suffering. When addiction continues in a patient with cancer, there is increased stress and frustration for family members and caregivers who are trying to help the patient. Addiction may mask the symptoms which are important to patient's care. So for example, if decrease in appetite is happening as a consequence of cancer and the person is taking cannabis, which increases appetite, so it will probably mask the kind of the impact of the cancer, and it might not lead to early catching up of the symptoms, or then there might be reluctance of providers to provide adequate pain medications if a person has been continuing to use substances or having addiction. There might be poor patient compliance with medical regimen and decreased quality of life. And because of these reasons, it is important, probably even if in a person with terminal cancer, to address or at least think about managing the addiction. Now, we think from the aspect of the family members as well, because they may have fears of setting addiction in motion through pain and symptom management. So when they are given certain medication to be given to the patient, they don't know how much to give, if especially if the patient has addiction. No, so they can be fearful of using controlled substances. Then their mind is that, are they doing injustice by not giving adequate medication, or are they doing certain problem by giving more medication than necessary? So from the family perspective or the caregivers, it becomes a kind of a challenge. And when the patient is not able to control his or her acting out in such situations, the family member may be driven away and patient isolation may occur. So, the patient may get frustrated that you're not helping me, and you go away. And the family member says, okay, I've tried enough. Now you manage yourself. Right. So I'll conclude. So, uh, in cases where addiction is identified, patient might be hesitant, the clinician may be hesitant, and hence, in cancers, addiction may be present in a considerable proportion of patients with cancers. Certain behaviors may indicate misuse or misuse of medications in patients who have cancers, and we should guard against being nihilistic, at the same time being overly cautious. So with that, I'd like to thank you for your listening.